Okay, so welcome everybody to my talk today, which is called Gaps and Challenges for the largest mental health provider in the USA, the criminal justice system. A little bit about me, just to introduce myself. I'm Dr. Lindsay Erst, and I'm the lead research scientist here at MHS. Prior to joining MHS, I conducted psychological assessments and specialized risk assessments for sexual offenders and provided treatment to male and female violent offenders who were on parole and living in the community. I'm also the consulting editor for a number of scientific journals. And for anyone out there who is new to MHS, Multi-Health Systems is a global publisher of scientifically validated assessments in the clinical, education, public safety, and talent assessment markets. We're located in Toronto, Canada, and have been in business for over 30 years. We publish assessments in over 50 languages and have a presence in 75 countries around the world, so we are truly a global company. So why would I refer to the criminal justice system as the largest mental health provider in the United States? Well, because it is, and it's not just true in the U.S. There's more than 10 million prisoners worldwide, and the prevalence of all investigated mental health disorders, doesn't really matter which one you're looking at, is higher in offender populations than it is in the general population. In fact, here's some data. It's from 2013 that looks at the percentage of adults in the criminal justice system with a mental illness. And what you can see from this is that there's more individuals with serious mental illness in prisons and jails than there are in state mental hospitals. Here's some more data. This is conducted by the Correctional Services of Canada. This was a report published this year, April of this year, actually. And although we know that men have high rates of mental illness, what we realized through this study is that the rates for women are even higher. In fact, most women met criteria for a current mental health disorder, 79.2%. And among Indigenous women, the rate was even higher, 95.6%. Now, when women who only had antisocial personality disorder or substance abuse disorders are not included in these statistics, the results still remain really high at over 60%. So despite this really high level of need, these disorders in both men and women are frequently underdiagnosed and poorly treated. And it's not just adults. In fact, the situation in juvenile justice might be even worse. Approximately 50 to 75% of youth encountering the juvenile justice system in the U.S. meet criteria for a mental health disorder, compared to the 14 to 20% who meet criteria in the general population. This means that the juvenile justice system is now the de facto mental health system for American youth. And this is important because incarceration of people with mental illness is a major public health issue with social, clinical, and economic implications. The balance between public safety and human rights has left corrections services with challenges in providing appropriate care for these patients. And I do mean patients. A paradigm shift is taking place in prisons where the population really needs to be thought about now as treated as patients and not prisoners. So how do the criminal justice system deal with this, and how are they going to be able to deal with this? Well, the 50-state report came out relatively recently, and it did provide some recommendations for what should be done. So they put out a statement that said, shortly after a person enters the criminal justice system, and as needed thereafter, he or she should be screened by trained staff for addictive disorders, mental illness, and the potential presence of both. Screening tools for substance use and mental illness are designed to quickly identify people who may have behavioral health needs. People who screen positive should receive a clinical assessment to confirm the presence of disorders and a recommendation for the appropriate type and level of services. So this is great. Recommendations are really important. They serve the basis for best practice, but it's often difficult to implement best practices when there's a number of real obstacles in the way. So I thought what we could do together today during this presentation is sort of break down this particular recommendation and see how we're doing in terms of meeting it. So the first part of this, shortly after a person enters the criminal justice system and as needed thereafter. So first off, what does it mean by shortly? When should screening really occur? Well, best practices suggest that within 14 days of arrival at the facility, I think in Canada, it's the recommendation of 3 to 14 days, that screening should take place. However, many argue that it should actually be within 24 hours of arrival. And the reason for this is because screening is typically for acute risk for harm to self or others. So we're talking about suicidality. So this is immediate need that typically needs immediate attention, in which case 14 days may be too late. So screening upon entry is important, but that last part of the sentence, as needed thereafter, that's what I really want to focus on, because the mental health status of an offender can change during the course of incarceration. So they can get better with intervention, they can get worse without intervention, or an offender who previously appeared well may have sustained a decline in mental health due to the stresses of incarceration. As a result, it's typically recommended that screening and assessment be conducted on a regular basis during incarceration, as well as prior to discharge, to ensure the changing mental health needs are continually met. Now, the funny thing about this is back in the 80s, we were actually pretty good about this. We were able to meet that need for continual reassessment, but there's been a steady decline in reassessing offenders that's been documented. Now, I think this is probably due to the burden that's been placed on facilities these days, as well as budget cuts that are being widely felt throughout the U.S. and the current political landscape. But really, it's just showing that the volume of offenders with mental health needs is becoming such a burden and overwhelming that the ability to do ongoing continual assessment has certainly declined. And it's a really important, crucial need that should be met because, as I mentioned, mental health concerns can arise or intensify during an offender's time inside. And this can lead to higher risk of victimization for the offender, both inmate on inmate or staff on inmate injuries, as well as increased harm to self and others. So it's really important to keep a close watch on the mental health status of an offender population. Regular screening and assessment is also important for understanding outcomes or the utility of various interventions that are put in place. So if you're going to go to the expense of putting an offender into a program, you want to make sure that program has the outcomes that were intended. So you want to be able to progress monitor whether or not the mental health status is changing as a result of the treatment or intervention that you've put in place. And the importance of screening and assessment prior to discharge also shouldn't be taken lightly. So this is required to facilitate transitioning the offender back into the community and ensuring a continuity of care with the goal of reducing recidivism after discharge. So back to our recommendation, the next part we're going to look at is the idea that this should be done by trained staff. So this is where our next gap is identified. So we know that resources are scarce, and so what a lot of prisons are doing is they're letting the frontline workers conduct the screening. And that's okay, and that's totally reasonable considering cuts to budget and resource problems. But those frontline workers need to be properly trained. So we know that when frontline workers or correctional officers are the ones conducting the screening, they're actually more likely to have false negatives, which means information disclosed to correctional officers is less than what is disclosed to a healthcare professional. So the offenders feel more stigma when speaking to their correctional officer than they do when speaking. They feel more free to disclose symptoms to a healthcare professional. And the correctional officers themselves feel it. They say that they feel like they don't have the right training to be conducting these screening assessments. They feel like they need more training on methods for establishing trust and eliciting information from offenders, things that, of course, the professionals are highly skilled and trained in. They need to know how to establish rapport. They need to understand how to elicit very sensitive information in a safe way. And they feel like they're really challenged in knowing how to properly ask questions about current symptoms in order to monitor them. There's simply not enough mental health professionals available to meet this need. And it's a costly resource for the institution, especially an institution that's facing budget cuts. So it does make sense that correctional officers are stepping up and filling this gap, but we need to make sure that they're getting appropriate training to do so. Turning our attention specifically to screening and assessment, it says that screening tools for substance use and mental illnesses are designed to quickly identify people who have behavioral health needs. So the purpose of the screening tool is meant to be an efficient way to determine who may need a more in-depth assessment. Oftentimes, though, it's just used to determine who poses an imminent risk to self or other. So like I said previously, it's being used to say, are you psychotic? Are you suicidal? If not, screening done, no need for a further assessment. But that's not always how screening should be used. There's many more mental health symptoms and diagnoses and illnesses that should be screened for to make sure that they're getting their needs met in the ways that they should. I'm going to combine this with the next part of the sentence, which talks about people who screen positive should receive a clinical assessment. So you'll notice here that they're differentiating between a screen and a full comprehensive assessment. So although the terms screening and assessment are often used interchangeably, they're really not the same thing. So screening can serve as a cost-effective method for identifying potential mental health problems that can be applied to everyone entering a system or facility. Assessment, on the other hand, is meant to provide a more extensive and individualized identification of mental health needs, only for those individuals for whom screening suggested it's warranted. Now, typically when I give this presentation, when I give it actually to a live audience, I'll give a poll. So I'll ask the people in the audience to indicate who in their institution is given a screen. Is it some offenders, all offenders, or maybe they don't know? And who's given a comprehensive assessment? Is it all offenders, some offenders, only the offenders identified first by a screener, or they don't know? Now, the results are typically mixed, whereas nearly everyone raises their hand to say that they do screening for all offenders. Certainly some don't. And among those that are screened, what's screened for varies greatly. And some said that they do comprehensive assessments for everyone, which I think is wonderful. I'd love to see the day where we have budget and resource to ensure that comprehensive assessment is carried out for all. But when budget and resource is scarce, we need to think about whether that's the right thing to do. So stay tuned. I'm going to talk a little bit about that shortly. Now, when I have done these polls in the past, there's also results from various national surveys that give feedback and tell you what sort of the status of the current situation is. They align very closely. So here's a word cloud that I actually made from a previous webinar I gave. We had over 700 registrants on the line. They represented 22 different countries, and they were all part of juvenile justice and corrections. So the word cloud is created such that things listed with greater frequency are seen in larger print. So you can see here that there's some words that have larger print than others, and you might notice that none was the strongest response that was given. So this was in response to a question of what screening instruments do you use? So what you can see here is that what's used varies greatly, and there's very little consistency seen across facilities. So if many of them aren't screening, or if they are screening, they're not using a standardized measure to do so, and what they're using is all over the map. So then I ask, well, what are you using for your comprehensive assessments? And the funny thing is, these two word clouds don't look very different from each other. In fact, I probably could have combined them, really. Again, none or not applicable were the two major responses. So they're not doing comprehensive assessments, or they're not using standardized measures when they do so. And again, the story is one of inconsistency. And this is also seen in the national surveys as well. And again, the fact that they overlap so much suggests that people don't know which measures are meant for screening purposes and which ones are actually meant for a comprehensive assessment. So that's really important as well. So I think the gap that we've identified is that although some facilities are using psychometrically sound assessments, there appears to be a general lack of consistency across facilities in the selection of the instruments that they use. They don't know which instrument to use and in what instance. And this is consistent with previous conclusions of researchers that there's no standardized procedure or process for evaluating the mental health needs of offenders across facilities. So when we're selecting a measure, I think I can give a little bit of guidance on this. So one thing you need to pay attention to is the sensitivity and specificity of the measure. You really need to take that into consideration. So research has shown that depending on the screening measure used, individuals might not get flagged. In fact, less than half of youth get identified despite having prevalence rates in the range of 50 to 75% of individuals are meeting criteria for a mental health disorder in juvenile justice, but very few of them are actually getting flagged by the screening measure. Similarly, in adult populations, research has found really low levels of identification of mental illness. So what this means is that the screeners that are being used are not very sensitive. On the flip side, you might have screeners that overflag, meaning that they have low specificity or a high false positive rate. So there's a trade-off that needs to happen here. So high sensitivity comes at the cost of specificity and vice versa. So you really need to know the sensitivity and specificity of the screeners that you're using to know if they're likely to under or over-represent the real situation. Now, you might have heard that it's better to overflag than not identify at all. So that way everybody gets pushed into having a comprehensive assessment. But here's the challenge. This could actually lead to an inefficient use of what are really scarce mental health resources. And this can result in a large number of offenders receiving assessments, which I think is a positive thing. However, it could also lead to a delay in treatment for those who are in highest need. So although screening can occur, as we said, within 3 to 14 days of entry into the facility, these comprehensive assessments that end up being recommended as a result of the screen, you can be on a waiting list for up to 3 months for that. And in situations where somebody is only in the institution for a short period of time, they might miss their opportunity to get help. So there's a tension that exists between accurately identifying the needs versus providing treatment for sort of pretrial offenders or those who serve shorter sentences. And when there's less time to make that decision, you really need to get them into the treatment sooner rather than later. So when resources are limited, it might actually be that efficiency may be the primary consideration. So again, it's this trade-off between sensitivity and specificity of the assessment tools. Jurisdictions with long waiting lists for treatment or short periods of time to offer treatment might be overburdened by a screening tool that overflags. In this case, a tool with high specificity and simply adequate sensitivity might be preferred. Another challenge is that you need to be aware of what the screener is actually sensitive to. So tools might be better at detecting severe mental illness, like I said, psychotic symptoms, risk to self or other, immediate risk, suicidality, but they're less sensitive to things like depression and anxiety. In fact, a recent study showed that 45% of individuals with psychotic disorders were identified by prison staff. They sort of stood out like a sore thumb, versus only 7% of individuals who met criteria for depression. So many of the screeners don't include assessment for ADHD either, attention deficit hyperactivity disorder. And this is another major gap because over 25% of the prison population, both juvenile and adult corrections, often meet criteria for this disorder. So this is something that's often overlooked and yet easily treatable. So tools do have their strengths and weaknesses. So it's not just about screening for suicidality or psychotic behaviors. You really need to think about, are you getting a quick screen of all possible mental illnesses that may be impacting this individual? You also need to know the characteristics of the staff member who's conducting the screener. So we talked about whether they're trained or appropriately trained, but the characteristics of the staff member themselves can influence the results. So studies have shown higher referral rates when screening is completed by a female compared to a male staff member. So that's just something you need to keep in mind. Also, because various forms of mental illness are present in the criminal justice system, and they're often co-occurring, or what we call comorbid disorders. In fact, comorbid disorders are probably the rule, not the exception. As a result, best practices would recommend the use of empirically based, psychometrically sound assessments for both externalizing as well as internalizing problems, with information coming from various sources to ensure the mental health needs are identified and can be addressed. Often there's too much emphasis put on externalizing disorders and not enough on internalizing. So one thing we've talked about today is that it looks like one of the primary obstacles identified is this lack of standardized tools for screening and assessment and an understanding of which tools to use in which instance. So I think that's where MHS is able to help and join the conversation. So MHS has a number of standardized, reliable, and valid tools used to assess mental health problems broadly defined, as well as specific disorders and screening measures. So sometimes when I do this talk, I get to do a small case study on ADHD or attention deficit hyperactivity disorder. And the reason I bring it up is because MHS is one of the publishers of the primary gold standard measures in the assessment of attention deficit hyperactivity disorder. So we are the publisher of the Connors 3, as well as its predecessors. It includes a clinical index that is going to both a ADHD index and a global index. So the ADHD index is simply 10 items that can screen for the likelihood that ADHD may be present. The global index is also only 10 items and can screen for the how likely it is that any kind of psychopathology may be present. And then it does a comprehensive assessment of symptoms of ADHD, as well as common comorbid disorders, conduct disorder, and oppositional defiant disorder. And it even has a brief screen for anxiety and depression. So this is a great measure that can be used in juvenile systems. We also have the Connors CPT-3 and CATA. These are performance-based objective measures of impulsivity and attention. And the Conners Adult ADHD Rating Scales, has a long, short, and screener version. So the screener version is the ADHD Index. It is the best set of items for distinguishing ADHD adults from non-clinical adults, and it's only 12 items. So you could certainly seek permission to just use these items as a screener to determine who should be considered for a more comprehensive assessment. So that's one way in which we have something to offer. The other area is in executive functioning. Executive functions are things like planning, attention, emotion regulation, self-monitoring, inhibitory control, all things that are evident in an offender population and all things that can be intervened on. So executive function is associated with criminogenic risks and needs and relates to recidivism in really important ways. So the CEFI, as we call it, Comprehensive Executive Function Inventory, and the CEFI Adult are standardized, validated measures that can help identify executive function strengths and weaknesses, inform intervention, and they also have progress monitoring to make sure that that intervention that's being put in place is actually effective. The other thing I wanted to alert you to is we have two measures that work really well together in combination. So that's the Justness Inventory Revised and the Conners Comprehensive Behavior Rating Scales. So together they can be used part of a standardized screening and assessment battery in juvenile corrections. So a multi-trait, multi-method approach, as you know, is recommended in correctional settings, and the JIR and Conners CBRS in combination will certainly provide that. So the JIR is a personality measure designed for use in delinquent populations, and the Conners CBRS is a broadband measure of youth psychopathology. So that means it measures emotional, behavioral, social, and academic difficulties in youth. So together, they can be used to identify mental health problems and frame them in a risk-need responsivity model. And you can use the results to help make treatment recommendations. So the JIR and the broadband measure together help identify the maturity level of the youth and are used to help inform placement and supervision decisions. So the JIR and Conners CBRS, as I say, complement each other in the assessment of both criminogenic and non-criminogenic needs. The nice thing about the Conners CBRS is that it also has a clinical index, like the other Conners measures that we spoke about. So it's 24 items, and an elevated score is suggestive of the diagnosis being present. And it screens for disruptive behavior disorders, learning and language disorders, mood disorders, anxiety disorders, and ADHD. So this could be your screening measure, and if flagged, you go on to do the full comprehensive assessment using the full CBRS. Now, evidence that these two tools work really well together, I just thought I'd put some up for you. So Dr. Robert Semmel, Dr. Bob Lurk, both are avid users of the JIR and support and encourage its use in juvenile corrections. They use it for court-ordered evaluations for disposition, post-adjudication cases, and for helping making decisions regarding level of supervision and treatment. And Dr. Semmel has actually published an article in the Journal of Forensic Psychology Practice touting the utility of the JIR for delinquency assessments. And actually, I typically would also give a case study if we had more time. I like to talk about this one case. It was actually a rather recent case, just happened last year. It was a 15-year-old male, and he was arrested for 3 attempted murders and alleged gang affiliation. It was a juvenile transfer case, so they were taking determination of whether he's going to be treated as a juvenile or as an adult. And in fact, the judge decided that the youth should not be transferred to adult court. And he actually noticed or specifically stated that the results from the JIR were a key factor in making his determination. So the JIR literally impacted this youth's life course. The outcomes for this youth had he been transferred to adult court. You can only imagine a far more negative trajectory for this individual. So it's quite a success story that the determination was that he would stay in juvenile justice, and juvenile justice would be able to meet the needs of this young offender. And the fact that it was the power of the results from the JIR that were key in making that determination, I think is fairly significant. And I also know that nobody likes to be the first one to try anything. So I just want to speak briefly about a rollout that's happening in Thailand. So Thailand already did a pilot, and now they're actually engaged in their full rollout. Their goal was for agencies to have standardized psychometrically sound instruments for the assessment of mental health, complex traits, and severe behavior problems. So they combined the JIR and Conners CBRS as a standard part of their assessment process. So comprehensive assessment includes the Connors CBRS for the mental health needs of the youth and the JIR for treatment recommendations. So CBRS is going to give the mental health indications. The JIR is going to do the treatment recommendations and give advisories on the level of supervision that's needed. And as I say, they started their pilot, they analyzed their data, and it was so promising and so positive that they decided to do a full rollout that all juvenile corrections across Thailand now include both these two measures as a standard part of their battery. And these two measures are fairly accessible. In terms of qualified users, I think many staff often available in juvenile justice settings are able to administer these measures. So these are some of the people who are appropriate and properly trained. Having said that, it can be administered and scored by those without advanced or formal training in clinical psychology or psychometrics, but it should be interpreted by someone who is what we call B-level at MHS. So this means somebody who's completed graduate level courses in tests and measurement at a university or has equivalent documented training. But if you need the COs to do the initial screen, that's certainly reasonable. Okay, so let's just take an overall summary now. So we have identified that the burden of high rates of mental illness are putting a strain on correctional settings. This is no surprise. This is not their intended purpose, nor are the staff properly trained in handling mental health disorders, but it's now a reality that this is something that we need to pay attention to. Best practice recommendations are certainly needed, and I think some have been put in place. The trick is the disconnect between the ability to follow those best practice recommendations. So the ability to follow them is completely dependent on resource, training, and the funding that's available. So those aren't always a match. We do the best that we can, but I think we identified some gaps where we might be able to do better. So one is the need for continual assessment. So although a lot of jurisdictions out there are doing screening, what they're screening for may not be sufficient. And then after that first initial screen, a lot of people, or the majority of individuals, are unlikely to be continually monitored. And that continual and ongoing monitoring is really important. And the person doing the screening and assessment needs to be considered. We've talked about the gap where the resources, the highly skilled resources, may not be as available as needed to meet the burden that's been placed. So frontline staff are being brought in to fill the gap, and that's okay. We just need to make sure that we equip them with the education and tools they need to be able to fill that gap effectively. And of course, there's a need for standardized, psychometrically sound screening and assessment tools. And I just introduced a few of them to you. If you have any questions about those or want to learn more, feel free to reach out. I'm happy to answer any questions. But I think this is one area where MHS can really play a role and make a difference. I think that it's not enough to just know that screening and assessment is needed. It's knowing which measures to use when and why, and of course, to understand the sensitivity and specificity of the measures that are being used. So that's all I wanted to share with you today. I thank you for joining me. That's my email address if you'd like to reach out. And I appreciate you taking the time to listen.